opportunity for some reflections, comments, questions from the floor. And we have got Carly here with a microphone, which you'll be wondering about if people have questions that they would like to ask. And we'll give our speakers a moment in case there's anything that they'd like to share whilst you're getting your juices flowing, as it were. But if you'd like to speak, if you'd like to raise your hand and indicate, and Carly will come to you with a microphone.
We've got some questions. Yeah, let's go for it.
This is a bit scary. I've got a question for Vandana. So coming from a nutrition, you look scared too now.
We got past that now. We're not scared anymore.
Coming from a nutrition background as well, how have you found marrying that in with the role and the fact that you're using that within the coaching role? I'm intrigued because a lot of our conversations around staying within your remit. So I was interested to see how you've managed that.
So that's a really good question, and I had all the doubts coming to your mind as well. So in my coachings, I think I asked a lot of questions from Ollie and Tim as well around this. So what I got is that it's okay to give knowledge to them. So using that combi model. So looking at that, if they're lacking knowledge on, for example, healthy eating, so you can provide information, and then you can coach them to use how to apply that information to them. So there is like a fine line. You can't just advise them, but how to give advice is like just asking permission and giving them information, and then coaching them to use that information, or how to setting goals, or how to apply that information. So bit of both.
Thank you.
And how have you found that yourself? How have you?
I definitely have. There's always a bit of an element of nutrition in the sessions. Probably I have a leaning towards that, but because I trained as a nutritional therapist, that holistic approach always comes through. So I think I put that across to the people that I work with, but I'm also very aware to kind of stay away from the advisory, I really think that you should do this, to kind of more information. So along the same lines really, but it's nice to see that you're able to use that side, because I feel a lot of us feel we can't always bring our previous experience to the role. But it's good to see that that's happening.
I think speaking with your clinical directors, and because when I had that confusion, so I speak to them as well in my clinical review supervision with them, and they were saying they're okay if I give some of the, but which was not good for coaching, but just letting them know as well. Sometimes it comes up because I used to get a lot of diabetes patient because of that, my nutrition background, and that's why I did a nutrition with type 2 diabetes program as well, 3 sessions of that, and they're okay with that. So it depends on your PCN as well. So how do they take it? How do they want to mold your role? So having a word with them would be good.
Yeah. Okay. Thank you.
It's a lovely question, and it's a challenge for all of us, isn't it? Because whenever we're in any interaction, we all bring stuff to it. We all do whatever. But I think as doctors, that's one of the things we've got really wrong, and we're learning is that it's all about this power dynamic, isn't it? We used to think that we were the ones that should tell people what to do because we were really clever. We've studied loads, and all of us will think that. We've got all this knowledge we're bristling with. But you have to think about the power dynamic. If you're telling someone what to do, they're following you. And actually the thing that makes the biggest difference in the end is people feeling in control, even more than having the perfect set of knowledge. So it's a really tough balance, isn't it? If there's modern knowledge we know people haven't got, and Donald's going to talk about metabolic health, and Richard and Kerry-Ann about modern understanding of chronic pain. It's really important if we think there's a real gap in their knowledge, but the way we help people to make sense of that is so important to keep them in control, and that's the skill that you're doing at coaching, isn't it? That's what makes coaching coaching. I think was it Jane here, and then Jane here, I saw her. If this lady would.
Hi. was a really great start to the day and very, very inspiring. I love the thing about loving our jobs. I certainly love mine as a health coach. Vandana, I'd be really interested if you could talk us through a patient journey from 200 people a month getting referred, and just what happens, because I think one of the things I found when I set up the service in RPCN 2 years ago, it's really hard to know what does health coaching look like, and I think the new framework has really helped with that, but it'd be interesting to know sort of someone joins your waiting list, when do they next hear from you, what happens, and what happens when they're done, because I'm struggling with patients being done.
So when a patient comes, a referral comes to us, so we put them in a waiting list and we inform them, we message them that we have received your referral and we'll get in touch as soon as possible. We inform them by sending that, and I think when they come at the top of the list, so we call them and we just like go through them, that what they want, or have sessions with them. And so what's your question, like what the actual journey of patient is, or how do we?
Yeah, so even going on to when somebody then you agree to have a session with them, then how many sessions might they have, and
that depends, because
how do you decide when they're done, or how do they decide?
As I said, like, there's no one fit for everyone, so we talk to them what kind of consultation they want. Is it face-to-face, or we offer them face-to-face, or telephone consultation, or video calls? So 3 options, so whatever they prefer. If they prefer face-to-face, we have to arrange in the surgery, or if they telephone call, so we call them, and whatever their concerns are. So based on that, so it's very varied. It's not just like 6 sessions or 8 sessions. So I'm still working with the patient for a year or so. So that's the flexibility given from our clinical directors or from PCN managers, and so that we can mold the sessions according to the patient's need. Or some patients we can just signpost them if we want, like for healthy or other services. So it's just 1 session with them. So there is not like typical session, and then when we discharge them and send the message to the referrer as well. So what we have done, just to let them know that how it went.
Thank you, that's helpful.
So does that answer your question? Or?
Yeah, no, it does. I think it's just interesting to know how it works in different practices, because I think we're still evolving to understand what best practice looks like. And you're obviously getting lots right, so it's good to know.
On an average, we see 6 sessions, but it's never like exactly 6 sessions.
And how many patients do you see in a day?
They're laughing. So it's 5. It's 5 patient, 5 to 6 sometimes. Some of us like we're working late, so it is. We need to work on that. So we are really flexible in timings as well. We give them early morning or late evening as well. So our team is really flexible, I would say. We all are hardworking. So
Yeah. Very good. Thank you.
Okay, do we have other questions around the room? Yep, here please. Sorry, Carly. Donald.
Yeah.
And then with the other hands, just let's look around the room. Yeah, okay, Thomas. And then, okay, go ahead.
Thanks, great presentations, well done all. So question for Aimee. So great presentation. You talked about some potential savings that can be made from increased activity, which is often different from cash releasing savings. But to make health coaching sustainable, we need to have a model of reinvesting those savings back into more health coaching and improving the quality. So are there any significant decent plans to recycle the saved money back into more health coaching so it becomes a sustainable?
The question. It's going to come at some point.
Good question.
So, part of the reason that I feel really hopeful at the moment is because of the introduction of integrated care systems and the money being closest to the point of care. Like, who doesn't sign up for that? You know, like, I don't need it nationally. I'm NHS England, and I shouldn't have it. It should be closest to the point of care. The challenge then becomes a bit of a postcode lottery and a power dynamic in terms of how that manifests in multiple siloed budgets. So elective care and urgent care and ambulances and local authorities and social care and healthcare all having slightly different budgets. But I feel really hopeful that at the moment is now with the change in legislation around those budgets all being pooled at ICB level. So that's part of why I feel hopeful. Maybe I'm desperately naive, but I am really hopeful because the evidence is really strong about that reinvestment. And I guess part of the reason that I shared some of that financial data and the data on populations is because actually it's going to be your voices talking in your ICBs that will bring about that change. It's going to have to be some hard leveraging in terms of making that economic argument, because it isn't cash savings, it's reinvestment. And that might bring with it some really uncomfortable conversations, including things like, I don't know, 1 in 7 people experience post-decision regret with high cost and high risk procedures like hip or knee replacements. Reinvesting that money may create a power dynamic within an elective team versus reinvesting that money elsewhere. So I think there isn't necessarily a national framework from NHS England, but we are contemplating what that would look like. So part of my reason for being here today is to hear and listen from colleagues about what I can take back to NHS England around the context of that, so that we can have these conversations continue to be live. So A, I'm hopeful. B, it's really challenging. And C, what I've hoped to do today is give you some information about the data so that you can start to leverage some of those power dynamics. It's not an easy answer, and I've probably not covered all of it, but hopefully that's good enough. Do you want to add anything to it?
I see Alan here.
Oh, sorry, Thomas. We're going to go Thomas, and then we'll come up there in a sec.
Yeah, right.
Thanks for your presentations. I really like the hashtag as well. That's we are all NHS. That's great. Just a quick question for Vandana. Is there any sort of outreach elements to your job as well? So sort of reaching those who don't really engage with primary care. So for example, working with your integrated neighbourhood teams or.
In my new lead role, yes. But as a health and wellbeing coach, I don't have that interaction with other organizations. No, not much.
Sure.
It's interesting, isn't it? And it'll be interesting to have the conversation today as groups of like, as a new role, you know, it's quite hard to kind of leverage the change in the system, isn't it? You know, the power often sits with the GPs and the decision makers, but often they're not the ones with the innovative insight. So I think there's this really interesting dynamic going on, isn't it? Where we really want people like you to be empowered, because this is the future. You know, we know that. And if you're going to make innovative solutions to help people who don't normally interact with primary care, make it easier for them to come in and join in or go out to them, whatever it is for them to access things, it's likely to come from us, I think, rather than the current leaders. I don't know, what do you think, Thomas? You do work in this area, don't you?
Yeah, no, that's why.
Please share.
Sort of stealing that. Yeah, no, I mean, we're working a lot. I'm from the ICB in South, from South West London. Thank you. And I think that's one of the sort of key areas. Is like, how do you engage with those who don't necessarily go to their GP? Sometimes because they don't, you know, they feel like they can't access their GP because of waiting times or those kind of things. So how do you, or you know, there's not a lot of confidence and trust because of that as well. So how do you think differently, like you said, and be more creative? And I think those integrated neighbourhood teams could potentially be a really good solution, because and bringing all those roles together, I think that will really help with connecting more with your local neighbourhoods and sort of understanding from the people who live there as well, to, you know, what matters to them and how can we help you maybe in a place where you are as well, so maybe they don't feel comfortable going into a GP practice. So it's yeah, a bit of a different way of working, but I think yeah, we're definitely not there yet either. Yeah, but it's something that's, I think that's, yeah, that will come in time, I think. And yeah.
Thank you, it's great. And I mean, the only thing I'll add is, I think, you know, I showed you the sort of team structure there, and what I've seen work really well in our neighbourhood already in our network is like a care coordinator, for instance, may go out to someone's house, literally knock on their door, and we've got some OTs working with us, and they build that confidence that actually maybe there is something that would be interesting for them to interact with the kind of services, and that trust and confidence builds up, and then they say, well, why don't you come and have a chat with a link worker, or can a health coach give you a ring? You know, you start to show a pathway of how it could be interesting for people, rather than just saying, right, if you don't turn up at the clinic at this time, sorry, you're crossed out. You know, so it is about thinking differently, isn't it?
Okay, there's a question in the middle here. Someone who's waiting patiently here. So, Carly, if you can zip up there. I've seen a question at the back. We haven't got long, so what I'm going to suggest is if people have got questions, stick your paw up. We'll take a couple, and then we'll let the panel respond if that's okay. So if you'd like to go first with the question, but we'll just take the question, and then the one at the back and the one over here. Go ahead.
So I was just going to say...
We'll go Ilanthi and then the lady at the back. And then, yeah.
I was just going to say, I don't know how many other people put their hand up who aren't health coaches. When, Ollie, you asked how many health coaches we got in the room, I did, and I think that speaks volumes, because I don't have health coaches' knowledge, skills and confidence, but I do think of myself in that role, which is a bit bizarre, so I'm a GP by background. So my question was a little bit, I think maybe one to think about, but you mentioned about the secondary care kind of specialist services, and I work in that area most of my time now. So I think there are people who are real advocates of this approach sat within secondary care services, and I think they're a bit lost as to how to kind of reach out and connect. So I think one for us as a community, growing community, to think about how we can connect in, but also I suppose, you know, is there a conversation about putting health coaching, health trainers, health and wellbeing coaches into secondary care, or do we grow what we've got in community and connect with our colleagues in secondary care so that they know that that's available in community? I'm a bit conflicted, but I just think it's an interesting. I wondered whether Aimee, particularly, you'd got any thoughts about that.
Okay, so we're going to hold the question. You're going to pass the mic 2 rows back, please, Ilanthi. Audience participation. This is what we're all about. Okay.
Yeah, hi. I've got a question for the whole panel. As health and wellbeing coaches, how do we resist the pressure that may come from clinicians or GPs for us to become clinically useful by taking blood, doing health checks, and then perhaps doing a couple of minutes on dietary advice after we've done that? How do we resist that pressure?
Okay, I think there were 2 people with hands up. Do we want to take those questions as well? We'll take one more on the front. If you're holding a question, remember people are not leaving after this session. They'll be available for tea and coffee. So if you haven't grabbed them here, grab them on the way out. But we'll take one more from the front, and then we'll go back to the panel.
Just a quick context question coming from Vandana's last point of seeing a generational change through acquired learning passed on through generations. So I've worked with the Federation for the last 15 months, helping them guide this, and it's a federation of 20 primary care practices, 5 PCNs. 2 of the PCNs have bought in, 3 haven't. Not all the GPs in the primary practices that bought in are actively engaged. How many primary care practices currently have coaches, and how many still are on the journey of being persuaded this might be a good thing to do?
Great questions. So I think we'll come back to the panel, and you can decide who would like to start and take your pick of how you'd like to respond.
So to your really helpful question about secondary care, it's kind of shape of the workforce, really, of like where the place is. What I didn't describe in my intro, because I've done a few things in my career, is that I led safe staffing tools of like what should the shape of the workforce look like to meet the outcomes of the population. And essentially, it's about what should the establishment or the shape of that workforce look like. So how many people, whole-time equivalents, skill mix. Then there's something slightly different about how they are effectively deployed. And those are 2 slightly separate things. So I don't think that there is a perfect answer of should they be in secondary care or should it be a community-based decision. I think that that relies on a number of factors. Now, I would say that because I live in Northumberland, and the land distribution is really relevant. So not just the needs of the people, but 85% of the population live in 25% of the land mass, and vice versa. So there'll be different nuances of both the travel, density of population, the needs of the population, and the skill mix that will affect that. So I don't have a perfect answer other than the principles of safe staffing, which is what are the needs of your population? What should the shape of the workforce look like, including skill mix, and then how that gets deployed. So I think it could take a varied approach. It could be based in secondary care. It could be linked back to PCNs and R's roles or integrated neighbourhood teams. But I think it really depends on the local demographic in terms of what those systems look like. But that's my answer. I welcome your challenge back, and equally other colleagues.
Well, I mean, interestingly, your comments are probably quite similar in a way about how do we, make the case that some of the more traditional medical teams will get on board with this. And I think this is about belief, isn't it? Really, what you believe in, And whilst ever, I mean, there's a little bit about what you get paid for as well. I'm afraid, in the contracts, if you get paid to take someone's blood pressure and ask them about smoking, you do get drawn towards that to some degree. But let's be optimistic and hope we're moving into an era where we can follow our hearts rather than our pockets a bit more. And I think that is coming more about with these new integrated teams. And I think it is about whether you believe it's worth spending time on different aspects of care, isn't it? So if you believe that you're going to get most, because I think nearly everybody in healthcare really is in it because they want to do the best. So if you believe your best is achieved by controlling someone's blood pressure with tablets or controlling their diabetes with tablets, let's say, I think you'll be drawn to that, doing the blood test, doing the medical things. If you start to believe that the chart that Aimee put up there, that actually the biggest impact in health is the behaviour people make, you will make more time for it. And I think we've just got to make that case. And I think it'll be the people in the room, it'll be the people you're working with, it'll be the results we get that will demonstrate that. And that's maybe one thing for us to think about collectively. How are we going to demonstrate the value of what we're doing? Maybe we'll follow that through the theme of the day. How will we demonstrate the value of things we're doing? Yeah, sure, please.
And I think sharing case studies with surgeries, so that impactful case study of behavior change, so that makes them realize that what you are doing actually and what changes you can make in the patient's life instead of just taking those things and having a word with the referrer if it is just for that, letting them know that okay, so that might happen.
Okay, thank you.
Can I ask one tiny thing? I'm sorry. And I think we've got Caroline Gibson in the room, haven't we? Is Caroline here? Yeah, of course. Yeah, sorry, I was looking right. And I know you've done some research recently, haven't you, around, it might be interesting to hear you a bit later on about the sort of, where you're using EQ5D, a really standardised measure to show a really sort of bankable change, and you've had some really interesting results. So I'm sure amongst us all, there'll be some great ideas around how to demonstrate this.
Thank you. But in a bid to keep to time, I know we could go on all day. I've got a couple of housekeeping notes, but first of all, let's say a big thank you to our first panel.